Hello, everyone. Good evening or good morning, depending on where you are. My name is Frank from Wisonic Medical. You are so welcome to attend our Wisonic Global Dandelion program, with mission to widely popularize the point-of-care ultrasound utilization in medical practice, such as anesthesiology, pain management, MSK, intensive care, and emergency medicine, in cooperation with different experts across the globe to do online webinars or in-person workshop trainings. So far, we have completed over 700 webinars nationally and internationally since 2020, attracted over 180,000 doctors attending, received over 3.2 million reviews and comments. This time, we are honored to invite 8 renowned MSK experts in the United States to participate in our program, MSK Ultrasound Webinar Series. In these 2 months, they will present a comprehensive webinar series about musculoskeletal, including lecture topics on orthobiologic therapies and ultrasound utilization in MSK practice, covering common body parts like shoulder, elbow, hand, wrist, hip, foot, ankle, and knee. Here, I would like to express our most gratitude to these 8 respectable experts. Thank you. So let me show you my screen to introduce today's webinar. So today is the 4th webinar of our MSK Ultrasound Webinar Series program. We invited Dr. Colin Rigney as speaker and Mark Castor as moderator to lecture with topic on ultrasound in MSK practice, hand and wrist. Mark Castor has abundant experience in MSK and ultrasound. He starts MSK and the cardiac diagnostic ultrasound profession since 2008, became ultrasound consultant since 2012, and MSK instructor since 2014. He is member of several famous societies like American Registry for Diagnostic and Medical Sonography Society and the Society of Diagnostic and Medical Sonography. Moreover, he is the regular moderator for all the 7 webinars in this MSK Ultrasound webinar series. So, Mark, could you please introduce today's speaker, Dr. Colin Rigney?
Well, good evening, good morning, everyone. I want to greatly appreciate Frank here putting on these seminars, and I want to introduce Colin Rigney. He has his doctorate in PT to the webinar tonight, and he is a licensed physical therapist whose career has been that of a physician extender. He also bridges the gap between physical therapy, traditional orthopedics, and sports medicine using musculoskeletal ultrasound. Colin is currently serving leadership roles as a managing partner, director of operations of modern physical therapy and sports medicine, as well as professor at A.T. Stills University in the physical therapy department, which he is teaching radiology and imaging. With his professional skills, Colin also serves numerous consultatory roles for multiple professional organizations and societies on a yearly basis. His academic background is he graduated from A.T. Stills University with a doctorate in physical therapy and general practitioner studies. He did his residency also at A.T. Stills University in the orthopedic physical therapy group. He's got multiple peer-reviewed scientific and professional presentations. Now let's welcome Dr. Colin Rigney to the platform here, and let's listen to what he has to discuss this evening. Colin.
Great. Thank you, Mark. And thank you, the team at Wisonic, Frank, for being so gracious with having us on. And this is a pretty cool thing to be a part of and impart some knowledge to people who are on their journey to learning MSK ultrasound. So what I'm going to do, I'm going to share my screen. We're going to get into the topic of tonight, which is how to use ultrasound to examine the hand and the wrist. Okay, so really, I broke this down into nine different anatomic structures. Okay, this is not a comprehensive exam, but in terms of breaking this down into bite-sized chunks, I think for our purpose of tonight and for most clinical applications, this would serve as a pretty comprehensive set of anatomic points to be mindful of. Okay, so one is the median nerve in the carpal tunnel. So we have Guillen's canal, which is volarly in the carpal, kind of in the volar wrist. Okay, you have the flexor tendons, the 6 dorsal extensor tendon compartments, so moving to the dorsal side of the wrist there, the dorsal joint recesses, the scapholunate ligament, the triangular fibrocartilage complex, the flexor tendon and annular pulleys, and the ulnar collateral ligament of the thumb, the UCL of the thumb. Okay, so let's get into our structures here. So volar side, we have these 3 structures: the carpal tunnel, the Guillen's canal, and the flexor tendons. So let's start with the median nerve. Okay, so when you have the median nerve, you want to start to best identify the median nerve, is especially for beginners. Okay, you want to learn how to identify it in the most clear place. And if you can see my cursor here, we're right at the mid portion of the forearm, and we're in short axis here. And so we're going to scan this distally to the carpal tunnel. Okay, so what does this look like? Okay, so here's a live picture of me demonstrating a scan. Okay, you have the patient positioned in supine. Okay, as is moving through the forearm and into the carpal tunnel. Okay, so as you see, as the cursor is moving there, that's the median nerve. We're tracking it cleanly. Okay, so this is a good setup, especially if you're just beginning. This is a great setup to learn how to identify these structures. Okay, so as we get further down, so we're in the carpal tunnel at this section. Okay, we're actually identifying that this is a bifid median nerve, meaning that it's compartmentalized into two different segments here, compromising a little bit of a larger surface area. Okay, so you see the one section here, one section here, and we'll get into a little bit of how to assess and measure it. Okay, so right here I'm taking a circumferential measurement of the nerve in short axis, and we're just gonna objectify this as it sits here in the carpal tunnel. Okay, so taking the measurement, we have a 10 millimeter squared measurement, which is kind of sits within the realm of normal. We're going to get into that a little further down in the slides. Okay, of what that means and what compromises. What are the objective measures that compromises normal versus abnormal? Okay, so again, coming into the carpal tunnel, taking a more static picture, what does this look like? Okay, if we do this correctly, we're going to get a picture that looks like this, what you're seeing here. These arrows, what you're looking at, this compromises the transverse ligament, the roof of the carpal tunnel, the flexor retinaculum transverse ligament, okay? And we're in short axis here, okay? Short axis. And you have the flexor carpi radialis outside of the carpal tunnel, okay, inside the carpal tunnel. This is the scaphoid flexor pollicis longus right here, okay? And then you have the flexor digitorum superficialis and the flexor digitorum profundus on the bottom. And right here is the median nerve. And then over off to the ulnar side, you have the pisiform bone. Okay, so the pisiform and the scaphoid compromises kind of the bony landmarks, ulnar and radial, that connects the transverse ligament, which compromises the roof of the carpal tunnel. Okay, so say you're having trouble differentiating how to find the median nerve amongst those tendons. Okay, so a good scan tip is to have the patient, or you can either passively or actively have the patient wiggle their fingers. Okay, and what you'll see is something that looks like this. Okay, so this is the tendons that are moving. Okay, we'll play it a couple times. The tendons that are kind of bouncing around. Okay, and this is the median nerve right in the middle that is not contracting. And this is a good way to identify the median nerve, because sometimes just statically it's hard to do, but we're using, again, the dynamic capacity of ultrasound to really determine what's a passive and what's an active structure. Okay, and you can do this for any anatomic structure in the body. Really, that's the beauty of using ultrasound. Okay, and we'll get to Guillen's canal here, so we're not going to spend a ton of time on it. Really, this is a structure where you want to be able to identify it, especially for those who are doing interventions in the area. And I have an example of what a median nerve dissection looks like under ultrasound guidance. You want to be able to clear this structure, especially if you're using the technique I want to describe, where you definitely don't want to put a needle through this area. So this is a good anatomic area to identify just in the volar wrist, especially if you're doing these procedures like I mentioned. Okay, so this is the pisiform. We're in short axis. You see we have the patient position is supined, okay, slightly extended over a gel bottle. This makes the structures more echogenic. You put a Doppler over it, we can see the arterial structures. You have the ulnar nerve right next to it. This compromises the Guillen's canal. Okay, so you see all this dark stuff here. This is the carpal tunnel. Okay, so you can see is if you're going to go ulnar to radial with a needle, that you want to clear this area. Okay, so I'm using anisotropy to my advantage, which is angle of incidence. Okay, so if I want to identify a certain structure like the Guillen's canal, I'll play it again here. Okay, so this is an area I want to highlight for this particular emphasis. I'm going to emphasize putting more pressure on the probe on that spot and keeping the rest of the area dark to kind of maximize my view. All right, so the flexor tendon, median nerve, and long axis. So we're going to take these same structures and we're going to turn the probe 90 degrees perpendicular. So we're going to have the probe kind of longitudinally on the volar aspect of the wrist. So this is a static image of what that looks like, okay? So we're looking at a long axis image of the volar wrist. On the bottom here, you have the flexor digitorum profundus, the FDP, moving. So left is proximal, right is distal. Over the top of it, you have the flexor digitorum superficialis, left to right on top of it, okay? And then superficial here, you have the median nerve, this darker structure. And then over the top, you have the flexor retinaculum transverse ligament here in short axis, okay? So say you're having trouble identifying, again, the tendons versus the nerve, because sometimes, especially for beginners, this can be a difficult structure to identify early in your learning process. Again, using the dynamic capacity of ultrasound, okay? So keeping a nice connection between the probe, the gel, and the skin. I'm gonna passively, or you can actively have the patient wiggle their fingers and you can see how the tendons glide and the nerve glides with it, okay? But very here dynamically, you see the tendons gliding and the nerve gliding over the top, okay? So I'll play it again. So the tendons are gliding and the nerves just stay fairly static, okay? And I have a couple examples of what an abnormal picture of that means later on here in the slides. Okay, so let's get into the dorsal wrist. Okay, you have the extensor tendon compartment. So there's 6 extensor tendon compartments. You have the dorsal joint recesses of the radiocarpal joints, the scapholunate ligament, the triangular fibrocartilage complex, and starting with the first dorsal compartment. So this is right over the radius, the radius and the radiostyloid. So we're going to get into the weeds here a little bit with the anatomy. Okay, so if there's no other way around, kind of instructing the subject, the hand and the wrist. There's a lot of anatomy here that you have to go back. If it's been a while for you in the hand and the wrist, this is likely going to be a refresher, or for some it may be like a really steep refresher. Okay, so we're starting again with the first compartment. So I have the patient kind of in wrist neutral over a gel bottle here with slight ulnar deviation. This is going to put those radial structures on a bit of a stretch and makes them easier to see with ultrasound. Okay, so we're going to start in short axis. As you see the probe here, this is the radiostyloid, the bone, this bright white structure you see. Okay, this is the abductor pollicis longus, the extensor pollicis brevis, and compromising the. You're not really seeing it clean here because it's not a pathologic view. This is the first compartment. Okay, so the tenosynovial sheath that kind of covers these structures is what you're seeing here. Okay, and because they're not pathologic, typically that's normal to not really identify the tenosynovial sheath over the tendons. Okay, so let me just talk a second here about, again, getting back to the anatomy at this part of the wrist. There's just a lot of stuff to be mindful of where using bony landmarks to identify and being kind of our lighthouse is very key. So Lister's tubercle is one of those. This is a home-based bony landmark. It separates the second and third dorsal compartments of the 6 tendon compartments. Okay, so the second compartment is comprised of the extensor carpi radialis brevis and the extensor carpi radialis longus. And the patient position here, as you see, we're in slight wrist flexion over a gel bottle. The patient's in supine. I like the supine position to do most of my wrist exams because it's very easy to manipulate. Sometimes if you have them sitting kind of sitting in a chair with their hand rested or arm rested on a surface, sometimes you find them kind of really adjusting themselves uncomfortably to get into that spot. And especially if they're in discomfort, we try to minimize that. So this is my preferred method to examine the hand and the wrist. So this is why we're seeing this. Okay, so again, patient is supine. You have this position here. This is the radius. You're seeing the bone in short axis, extensor carpi radialis brevis and longus, and you see this darker kind of halo surrounding it. That's the tenosynovial sheath. Okay, Lister's tubercle right in the middle, separating the second and third compartments. Okay, so off to the right, this is ulnar. Off to the right or off to the left, this is the radial direction. Okay, so getting to Lister's again. Okay, again being that separator between the second and third compartment. Remember the third compartment, again, that anatomy. Okay, the third compartment is the extensor pollicis longus. We're in short axis here, Lister's. Okay, separating the second and third. The third compartment, again, extensor pollicis longus. Again, this is short axis. Okay, so We're going to demonstrate on a live clip what that looks like. So identifying Lister's tubercle right in the middle, okay? Right off to the ulnar side of it. This is extensor pollicis longus. And using the dynamic capacity of ultrasound, I'm going to passively wiggle their thumb just to help me clarify and identify that tendon, okay? So use all that to your advantage as you have the ultrasound in your hands. Don't just make it a passive static tool. This is an active study. You're going to really use ultrasound as the stethoscope to the musculoskeletal system. You're going to place it on the patient's skin, and this is going to give you a nice feedback of what's going on under the skin, okay? So that includes everything from static and active images, okay? So you're going to see a lot of that in this talk here, how I utilize the dynamic capacity of ultrasound. Okay, so let's go to the fourth and fifth compartment, okay? The fourth and fifth compartment consists of extensor indices, which is your index finger, okay? And the fifth compartment is the third and the fourth digits extensors, okay? So patient position is the same position here, okay? We're in supine, flexed over a gel bottle, and you're looking at these structures here. You have extensor indices and extensor, the third and fourth compartment here, the extensor digitorum communis. Okay, so I'm blocking the index finger. I'm having the patient move her third and fourth digits, and you saw those moving there. Okay, and the fifth compartment consists of the extensor digiti minimi. Okay, so the fourth compartment is extensor indices and extensor digitorum communis. The fifth compartment is extensor indices. And what you're seeing here is that pinky finger moving. Okay, the pinky finger moving next to the ulna. Okay, and this is the radius and the ulna, the radial ulnar joint. The extensor digiti minimi sits right next to the ulna. And the sixth dorsal compartment, this is the extensor carpi ulnaris. Okay, so you see the position we're in here, same position. We just adjusted the probe. We have the patient over a gel bottle with slight radial deviation to put that tendon on a bit of a stretch. Okay, it's going to allow us to see it better under ultrasound in the gel. Okay, and this is the ulnar groove you're looking at. Right in the middle, right here is the extensor carpi ulnaris. And we're going to watch it we're going to watch there we go. We're going to watch it play. Okay, so as I'm scanning here, you see the extensor carpi ulnaris right in the middle, the groove of the ulna. Okay, and because this is not a pathologic tendon, you're not really seeing the tenosynovial sheath with a lot of clarity here. Okay. And we have a couple of examples of what abnormal looks like of that. Okay, going over to the radiocarpal joints. Okay, why are we using this as part of our exam? Okay, there are a number of different reasons we're doing this. Okay, the main, this is not comprehensive, but the main sections. The main reasons we're going to look here are for dorsal wrist ganglia, joint effusions, wrist effusions, bony erosions, and synovial hypertrophy in the cases of inflammatory arthropathies like rheumatoid, psoriatic arthritis, and those sorts of diseases, and gout. Okay, so if we do that picture right, so this is the position here. Again, patient supine, hand slightly flexed now over a gel bottle with the patient with the probe and long axis over those structures. Okay, we have a picture that looks like this. You have the radius, the lunate, and the capitate. Okay, so left is proximal, right is distal. These look like three snow-capped hills. Okay. And then sitting in between these synovial infoldings here, okay, these are what normal baseline looks at this part of the wrist, okay? And then you have some extensor tendons over the top that we're catching, okay? But we're looking at these cortical margins are smooth and uninterrupted, okay? So relatively smooth and uninterrupted. There's no swelling or effusion sitting in between the bones. The synovium sits nice and uniform and symmetric within these bony landmarks. This is kind of the hallmark of what a healthy looking dorsal wrist is. Okay, and then the scapholunate ligament. Okay, the scapholunate ligament is kind of a crucial piece of anatomy in the dorsal wrist that provides a lot of stability for patients who are axially loading their extremities, like a push-up position, or any numerous sporting activities. Okay, this is a key piece of anatomy to evaluate here. So when somebody complains of dorsal wrist pain that is really provocated with pushing or axially loading the structure, this is a place we're going to look. Okay, so what you see here is the probe is oriented. This is the dorsal aspect of the scapholunate ligament. You see how it's oriented. This is how we're going to evaluate the structure. When you're evaluating this area, okay, this is again a lot of anatomy kind of condensed into a small geographic location. Okay, so to get to the scapholunate ligament, palpate Lister's tubercle. Okay, so this is that bumpy spot on the radius. Okay, you identify that bumpy spot on the radius, the Lister's tubercle, and then gently slide your finger down distally. The first gap you fall into is where the scapholunate ligament sits that connects the scaphoid and the lunate bones. Okay, so this is a live clip that's going to demonstrate that. And so before I play it, you see how the patient is positioned. We have that same position. Again, we can do most of our work here. This is just a nice position to be in to evaluate just about any structure of the wrist. Okay, this is the Lister's tubercle right in the middle. Okay, and you see the probe position, short axis over it. Okay, so we'll play the clip. Okay, and then as we go, the probe is going to slightly move distally, and then you see the scaphoid and the lunate, and then the structure connecting the two bones is the ligament proper. Okay, so the dorsal aspect of the scapholunate ligament, which is the main part of the ligament, when there's a disruption or a tear, this is where you're going to identify it. So this is a bit of a long clip, but I'm going to let it play because I want to show you how to dynamically evaluate the area. So what we're leading up to here is, number one, we identify the area. Okay, coming down from Lister's tubercle. Oops. Okay, so here we go. We'll catch it back. Okay, so coming down from Lister's tubercle to the scapholunate ligament. So what I'm going to do here is going to dynamically stress the area. Okay, I'm going to take my finger on the triquetrum on the ulnar side of the wrist. I'm going to block it, and I'm going to stress the wrist in radial ulnar deviation. Okay, and what I'm doing is I'm stressing this ligamentous structure. Okay, this is a healthy ligament, so you're not seeing any gapping or paradoxical motion, which usually comes with some type of tear. Okay, so this is what a healthy ligament looks like. And this is the preferred method of dynamically stressing that area is. Okay, there's other ways you can do it. You can do the dynamic grip test. I found that's a little bit harder to do with ultrasound. It's better to do if you have fluoroscopy or some kind of radiographic method of evaluating. But with ultrasound, I found this to be much more sensitive and easier to do. Okay. Going to the ulnar wrist, the triangular fibrocartilage complex, which is the TFCC, and the ECU, which is the extensor carpi ulnaris. Okay, we're looking here at long axis. So this long axis image, left is proximal, right is distal, and you have the ulna bone here, kind of being your main bony landmark on the proximal side. The triquetrum on the bottom, the lunate. This is the radius, and this triangular kind of infolding here. This is the triangular fibrocartilage complex. Okay, the position of preference here is, again, with the patient in supine, flexed over a gel bottle, but you want to place the probe, or you want to place the wrist in slight radial deviation to what happens there. The arthrokinematics of the wrist is, with radial deviation, the radius will drop down some and volarly, and it's going to allow you to see the depth of the triangular fiber, the TFCC, to its full extent. Okay, so if you're not catching the radius all the way on the bottom, you're likely not visualizing the TFCC to its full depth, to the capacity of ultrasound. Okay, this where the asterisks are, this is a meniscus homologue, which is a fancy term for a synovium, joint synovium. Okay, so what a color schematic looks like of the same picture here. Okay, you have the ECU, the extensor carpi ulnaris, on the top. This is the acoustic window to visualize everything that's beneath it. The ulna off to the left here, proximally. This gray outline is the bucket of the TFCC, radius on the bottom. The yellow constitutes the meniscus homologue, lunate, and the triquetrum as your other bony landmarks. Okay, going to the fingers, the flexor tendon, the metacarpophalangeal joint, the joint capsule, in the A1 pulley. Okay, there's a lot of anatomy here, guys, that we can really get into the weeds with. I'm going to keep it fairly simple and straightforward. Most of your trigger fingers, so when the people whose fingers are getting locked into flexion and they have to kind of bend it, or they hear a clicking there, most of the time, and I'm generalizing here, most of the time that is your A1 pulley. Okay, and I'm going to start with that. Okay, so what we're looking at here is a longitudinal view. This is the metacarpal. This is the proximal phalanx, and this is your flexor tendons moving left to right, with left being proximal, right being distal. The arrow you're looking at here is the A1 pulley. The A1 pulley actually extends a little bit further proximally over the metacarpal. Okay, it's a pretty decent size piece of anatomy. That the A1 pulleys are ligaments that are circumferential in nature. They function to kind of fasten down the flexor tendons of the fingers so they don't flop around. Okay, the nature of anatomy is very beautiful, how it was innately designed by our creator. Okay, so that's what the A1 pulleys really function as here. They function to keep the flexor tendons really guided and gliding in the way they were intended, so they're not flopping around. Okay, what a color schematic looks like of this. Okay, so a little bit better outline here for us to visualize. You have the VP stands for volar plate, or the connective tissue. Okay, that kind of connects the two bones of the metacarpal and the proximal phalanx. The flexor digitorum profundus tendon is the blue, flexor digitorum superficialis in the red, and on the top, the annular ligaments in purple. And again, this is kind of a overgeneralized depiction here, but really this ligament really extends a little further proximally, kind of over the metacarpal. Okay, so point 9, the ulnar collateral ligament of the thumb. Okay, this is the difficult exam to do, guys. Okay, so this is one really, it takes a lot of practice, and it really takes 2 hands and a lot of gel. Okay, so what you're looking at here is kind of the preferred method of setting up the hand and the thumb for a good evaluation here. Okay, so this is the probe position. So remember, the ulnar collateral ligament connects the proximal phalanx and the metacarpal, the first metacarpal. Okay, and it prevents the thumb from valgus stressing. So this is an ultrasound image of what that looks like. What you're looking at on the left here is the first metacarpal. On the right, this is the proximal phalanx. And this triangular kind of infolding here, this is the ligament proper of the ulnar collateral ligament, okay? And then this structure over the top, this is the aponeurosis of the adductor pollicis that kind of sits as the fastener of these this anatomic structure. So it really fastens down the ligament, and it acts as the dynamic stabilizer from valgus stresses between these 2 bones. Okay, so kind of a color schematic outline of what that looks like. You have the first metacarpal on the left here, proximal phalanx on the right. This red structure here, this is the ligament proper, okay, the ulnar collateral ligament. The yellow is the outline of the adductor pollicis, the aponeurosis, that again acts as kind of the fastener between the muscle of the adductor thumb, okay, which brings the thumb to the rest of the hand, okay, and it's a dynamic stabilizer of the ulnar aspect of the thumb, okay. And this is often a structure that's involved with what's called your Stenner lesions, where an excessive valgus stress kind of violates these structures at the proximal phalanx typically. Okay, so I have some examples of what that looks like a little later on here. Okay, so a dynamic evaluation of what that looks like, okay, because this is kind of a 2-handed evaluation, what you're going to see is the replay of the cine clip of this moving here. Okay, so this is what a healthy anatomy looks like in the area. So metacarpal, proximal phalanx, you see the ligament, and the adductor pollicis tendon over the top acting as the fastener as we're stressing the area, okay? So again, that's what healthy looks like. I have a couple examples of what abnormal or pathologic looks like as well. Okay, so I'm gonna get into some common pathologies in the area, okay, in the hand and the wrist specifically, okay, because that's what we're talking about today. This is not comprehensive. Okay, I'm gonna detail kind of what you're most likely going to run into in the clinic in the hand and the wrist region. So first of all, carpal tunnel. Okay, so the median nerve inflammation. Some characteristics of what that is. Okay, there's a few different ways to measure and objectify median nerve swelling and pathology in the area. My preferred method is the quick and dirty method. If I can be as efficient as possible while still being very objective and using what the evidence is, then I'm going to take it every day of the week and twice on Sunday. So this is a particular study that I reference using this cross-sectional image, using the pisiform and the scaphoid as the inlet with the proximal aspect of the carpal tunnel, which is typically where you're going to find your nerve swelling. This study took a bunch of patients, basically with this criteria, ended up with 82% sensitivity, 87% specificity. We're looking at somewhere between 8 and 12 millimeters being kind of the range of normal. Anything outside here, so anything outside of 12 to 15 is really suspect for objectively identifying median nerve swelling that's consistent with carpal tunnel syndrome. You see this this particular nerve is 25 millimeters squared, which is what you're seeing right in the middle here, being like this is pretty obvious. This is one that I wanted to show because it's very easy to identify. This is what a no-brainer kind of median nerve inflammation consistent with carpal tunnel syndrome looks like. Okay, so you have enlargement of the median nerve. It's definitely darker, which means it's inflamed, stands out amongst the other tendons, which are a little bit brighter, as well as the bulging transverse ligament. So you see how it's kind of displacing the ligament on top, which is also created some scar tissue and adhesion to the nerve at the area. Okay, so and the other characteristics are flattening of the nerve of the distal tunnel and the decreased mobility of the nerve, which are really more dynamic kind of measures. And I'm going to show you what that looks like here. So we're going to take a longitudinal view of these structures. And what we're doing here is dynamically assessing the mobility of the nerve. I'm going to let this play, but first I want to have you fix your eyes to this portion of the screen, okay, where I'm moving with my cursor. This is the distal aspect of the view. On the right or the left is the proximal aspect. So right is distal, left is proximal. Remember, on the top, this is the nerve. On the bottom, these are your flexor tendons. So flexor profundus, flexor superficialis. In this maneuver I'm going to play here, this is the patient kind of wiggling their fingers just like this. And what you're going to watch is you're going to see some compression of the nerve here. I'll let it play. So you see right here how the nerve is being compressed, okay? And then proximal to it, there's a lot of swelling. So you see the diameter difference between the proximal end and the distal end. Remember, inflammation in nerves, if you're looking at your mononeuropathies, is specifically your carpal tunnel in this instance, the swelling is always going to occur proximal to the level of entrapment, which what you're seeing here is the entrapment, and what you're seeing over here proximally is the swelling. Okay, so this is the beauty and the dynamic aspect of ultrasound and why we use it the way we do. Is just a nice way to really confirm what our physical exam is likely already telling us. Okay, so I'm going to show you what a setup for a carpal tunnel injection looks like. Okay, so now more than ever, there's many non-invasive or minimally invasive ways to release the median nerve and from its adhesion to the roof of the carpal tunnel. Whereas before, maybe I don't know, some other experts could probably help me out here, but the releases at least prior to ultrasound and some of these technologies that have been coming out, like your Sonics or even just your basic ultrasound guided hydrodissections of the nerve, where you're doing these open releases where the scar tissue will form down kind of immediately afterward and sometimes result in suboptimal outcomes. Okay, where now we can do this with a needle under ultrasound and get pretty similar results in a lot of cases. Okay, so this is our preferred setup. We have the patient in supine, and what you see here is that there's a gel bottle kind of underneath the towel. The sterile setup is what you're seeing here with the probe cover, the sterile gel, and the needle placement. Okay, so remember I talked about the Guillen's canal and why we clear it. Our preferred method of releasing the carpal tunnel minimally invasively under ultrasound guidance is an ulnar to radial approach. Why we like this is because this cross-sectional view allows us to see the needle moving. You can move at the structures both from underneath the nerve. You can release the nerve from the tendons. You can move right at the nerve with the needle, or you can go right at the nerve to the roof of the carpal tunnel with the needle as well. So I'm going to show you a little example of that, what this looks like under real time, okay? Before I let it play, what you're looking at here is a cross-sectional view. Your median nerve is right in the middle here, okay? This, on the right side is the ulnar side, on the left side is the radial side. And what you're seeing here is the needle moving from ulnar to radial in plane with the probe, okay? So we'll let it play. And what you're watching is the needle kind of traversing. It's kind of navigating its way here to just deep to the nerve. So separating it from the flexor tendons. Okay. And then we're going to redirect it. We're going to kind of come right at the nerve a little bit. And what you're going to see is some displacement of the nerve. Okay. Doing a little bit of dissection. Okay. So you see now is very superficial. You can do your release from the roof of the tunnel here, the transverse ligament, flexor retinaculum with the needle, separating the nerve from the area. See the displacement we've done? Okay. So this is a very minimally invasive way, a very low leverage method of releasing the tunnel, releasing the nerve from its adhesed kind of pathway in the carpal tunnel. Okay, definitely a much definitely an easy way to get patients in and do that if you have ability in the training. Okay, trigger finger. Okay, so A1 stenosing tenosynovitis. Okay, so tenosynovitis is inflammation of the tenosynovial sheath. Okay, so that's the itis, tenosynovitis. Okay, so what you're seeing here is a little bit of a cyst. This is a cyst. You're looking at a long axis view of the tendons. This is the proximal phalanx, the metacarpal, and what you're seeing here is the flexor digitorum profundus, flexor digitorum superficialis. And this is statically, this is a dynamic picture I'm going to play, but I want to describe it first. All this dark stuff you're seeing is scar tissue that is going to become more prominent as we move these structures in this method here, okay? So you see as we move, you see the scar tissue, all this junk right here kind of form and create the adhesion. So this creates the locking sensation at the A1 junction, the A1 pulley, okay? The extensor carpi ulnaris. So you're seeing a couple different things here. This is a tear in the extensor carpi ulnaris. This is a short axis view where what you're seeing here is a tear that takes up more than half the diameter of the tendon, as well as some inflammation of the tenosynovial sheath, which is this dark halo that's surrounding the tendon itself. And if you remember from the earlier portion of the slides where we're looking at a healthy extensor carpi ulnaris, you really weren't even seeing the sheath at all, right? Okay, but when there's inflammation, it becomes really obvious. And so what you're seeing there is a tear right in the middle, combined with some inflammation in the sheath. And this next slide is really a more pronounced version of the tenosynovitis. So the tendon proper you're watching here. So the tendon itself is relatively uninvolved in terms of pathologic appearance, but surrounding it, you see a lot of inflammation surrounding it. You're going to find this commonly in people who play a lot of racket sports, sometimes in your golfers, and those sorts of recreational or professional patients. Manual labor, oftentimes as well, you will see this. Okay, people who are having to manipulate tools with their hands can often generate this type of pathology. De Quervain's. Okay, so if you recall, de Quervain's is inflammation of the first dorsal compartment. Okay, so on the radial side. Okay, remember the first dorsal compartment consists of the abductor pollicis brevis, or abductor pollicis longus and the extensor pollicis brevis. Okay, that comprises the first compartment. And also, if you remember from the earlier slides, you were really not able to see the sheath at all. Okay, but in this case, you see the swelling in the first compartment. Look at this halo that's surrounding the first dorsal compartment. Okay, so the abductor pollicis longus, extensor pollicis brevis, and the swelling that surrounds the compartment. Okay, and then this is the the radiostyloid. You're looking at in cross section. Okay, this is the preferred setup for a de Quervain's injection. So we're looking with the probe here. So the sterile setup with the probe. Needle is moving dorsal to volar. Moving dorsal to volar because we want to avoid the neurovascular structures, the radial nerve, and the artery that usually sits on the more volar side of the wrist here. Okay, so what does this look like live? Okay, so what you're seeing here is the needle moving into the sheath. Okay, taking careful attention not to actually fenestrate the tendons because these are a little more delicate. We don't want to create a surgical procedure if we can avoid it. You're looking to move this needle just right into the sheath and deliver the medication or the injectate of your preference. Okay, and this is going to get the job done for that procedure. Okay, so what we have here is ulnar collateral ligament tear of the thumb. Okay, so that same image we had previously, you have the the metacarpal, proximal phalanx here, and then keep your eyes focused in between the two arrows. This is the ligament proper that sits in between. Even in the static view, you can see this dark kind of void here. This signifies where the tear is going to be located. So this is a live clip where we're stressing the thumb. We're placing a valgus stress on the thumb to watch these structures kind of gap and open up. So you see it's pretty evident once you see it. I'll play it again. Even though you can see it statically, dynamically, it's again really obvious. And when you're doing it live, it just confirms it's just a really good way to confirm your physical exam findings. Remember we talked about earlier about the dorsal wrist and the main reasons why we're looking back there. So you got your synovial cysts, ganglion cysts, you got your synovial hypertrophies, inflammations from your gout, inflammatory arthropathies, psoriatic rheumatoid arthritis, and those sorts of things. Okay, this is a case of what you're seeing here. This is a patient with gout, extensor, fourth compartment, indices. And what you're seeing here, all this inflammation surrounding the tendons, is just that, it's inflammation. But what's different here than your standard kind of effusion, okay? What you're seeing is this is synovial hypertrophic changes, because these are tenosynovial sheaths that surround the tendons. And so what you're seeing here, this bright stuff you're seeing is complex. Complex meaning it's highly viscous. This is not your standard kind of fluid and inflammation, okay? So you see this dark stuff. When you see the more dark isoechoic type appearance, this is standard inflammation. But when you see this mixed echo appearance, mixed echo meaning you have your dark and your bright complex fluid, this is more atypical in terms of finding, and this is generally associated with these inflammatory arthropathies, such as, again, like your gouts, your psoriatic, and your rheumatoid arthritis. Okay, so a long axis image of that same structure, a little more prominent here, a little more obvious, where you're seeing the extensor tendons. Left is proximal, right is distal. You see this bulging of the tenosynovial sheath. Okay, again, this complex fluid. You see this mixed echo appearance, this bright stuff. Okay, this is synovial hypertrophic changes combined with some just straight inflammation. Okay, these are going to create a lot of adhesion in the structures, and it's going to create a lot of pain associated with moving the hands and the wrists. That's why people who have these diseases, and especially uncontrolled diseases, experience that type of pain with movement in the areas. Okay, and this is an example of a patient who we caught on the early side of the rheumatoid diagnosis. So this is a patient who came to the office with pain in multiple joints, and it was kind of a rapid onset. No significant history in terms of like new occupation, new activities, or any new recreation or anything like that. It would just kind of happen insidiously. And again, it wasn't just one joint; it was bilateral wrists and ankles and knees, kind of all around the same time frame. Okay, so this is one of the wrists. We're looking at the radiocarpal intersection here. So before I let the video play, this is the radius. This is the lunate. This is the capitate. And what's different here compared to the earlier pictures where I was talking about, and they would look very, very normal. You didn't see all this stuff in the middle. Okay, what is this stuff? I'm going to get into that. This is what an example looks like of a wrist that's very inflamed. Okay, so I'm going to let it play, and I'm moving the wrist into just gentle extension, flexion, and what you're seeing there is these complex appearing structures. Okay, these are synovial hypertrophic changes. Again, this mixed echo appearance with the fluid and the synovial hypertrophic changes. This is kind of a hallmark of the disease and inflammatory arthropathy. At this stage of the evaluation, we were not willing to say what it could have been because we hadn't done a blood panel or any further workups yet. But this is essentially the blood panel did come back for rheumatoid, so that's what it ended up being. So our suspicions were right, but again, sticking to our topic of ultrasound in the area today, this is very hallmark of what that looks like, especially on the early part of the disease. Another thing I want to point out is you see some early erosions of the bone happening here. So you see the cortical surface, the lunate and the capitate starting to erode just ever so slightly. Again, on the early side of the disease, but you see these aren't necessarily all smooth and uninterrupted surfaces. Again, you'll see them a lot more in the advanced stages. It'll be a lot more prominent, but in this stage, I think it's key to point that out as well. Scapholunate ligament dissociation. Okay, so obviously this is not an ultrasound picture. This is a fluoroscopy picture. In our practice, we have multiple evaluation tools because we're an integrated practice. This is a case where we had scapholunate dissociation. Somebody who had a fall on an outstretched arm, didn't fracture their radius of their scaphoid, but had persistent dorsal wrist pain. What you're seeing here is the posterior anterior view. Okay, so this is a normal view, meaning no stress. And then this is, you remember I talked about a clenched fist view. This is probably the preferred method of doing it under fluoro, where clench the fist, it stresses the scapholunate space, and you see the gap open up. This is very atypical for a in a wrist that's normal. Okay, so again, static, dynamic. This shouldn't open up at all. So if in a healthy wrist you clench a fist, it should still look the same as you see on the left, but as you see on the right, it gaps open pretty significantly. And so what does it look like on ultrasound? Well, you get something that looks like this. Okay, so scaphoid, lunate, and then this gap between the middle. There's no ligament, there's no tissues connecting the two bones here. This is a clenched fist view, so it's pretty evident at this point when you combine your physical exam with what you're seeing on ultrasound, pretty consistent with the scapholunate ligament tear. Okay, so a dynamic view of a scapholunate ligament tear. Okay, so this is a live clip of me doing, if you remember earlier on, the ulnar radial deviation, stressing the triquetrum and in that radial ulnar deviation direction. What you're going to see here is kind of a piano key view of the scaphoid moving down. Okay, so it's paradoxical motion, and you see the ligament open up here. Okay, in a healthy wrist, you shouldn't see hardly any movement at all. Okay, so I'll let it play again. So you see the separation here, where the scaphoid kind of piano keys down. Okay, that's atypical. One more time. And you see this slight gapping in the middle, this dark space, fluid where there shouldn't be fluid, signifying there's a tear. This dark is fluid, and the bone moving in a way that shouldn't. Okay, so that is the end of my slide. I'll stop the share here, and I'll kick it back to the host. Thank you guys for your time and listening.
Great presentation, Dr. Rigney. Loved it. We had a lot of great comments on the scanning videos, especially on the pathology. It really makes it clear when we see normal anatomy, how easy it is to kind of pick up pathology going on.
Yeah.
Especially hands and wrists are very difficult to scan. Got a lot of questions here for you. Do you have a few minutes to answer a handful of questions?
Yeah. Sure.
Great. Let's pull them up here. First question. I know you kind of discussed this earlier, but how easy is it to see trigger finger, and what do you look for?
Yeah, so trigger finger, easy is kind of a, I guess that can kind of be a trap question, but with a little experience and knowing what to look for, it can be, it shouldn't be that difficult. What you're looking for is you're really going to see it on your dynamic scan. So when you're looking with the probe and long axis over the hand, okay, and you're dynamically, you want to be able to replicate, because that patient's always going to tell you what's making it click or catch. You want to be able to replicate that, number one, and just put your probe on it. And when you're evaluating trigger finger, long axis is the best way to view it. And you'll typically see some darkening or thickening above the flexor tendons during those dynamic movements, typically with digital flexion is where you'll see it.
Yeah, kind of going on that same question, another gentleman wants to know what direction would you inject the A1 pulley, long or short axis?
Yeah. So with long or short axis, it's the dealer's choice. I think that there's actually, I'll actually say there's three different ways to do it. If you're going to go long axis, where you're going, typically it's going to be distal to proximal with the probe and long axis. That's going to be a more, or as I would say, a less patient-friendly approach. So the alternate methods would be probably the preferred method for the patient, and a little bit easier maybe for the provider is a short axis view, meaning you're going to visualize the tendons in short axis, and the needle is going to come from, if it's the index finger, it's going to come from radial to ulnar, or if it's one of the other, the third or the fourth fingers, you would go ulnar to radial with the needle, with again visualizing those structures in short axis.
Great. Next question here. Do you use a high frequency or hockey stick transducer, and why? That's
a good question. I would certainly advocate for using the hockey stick if you have it. Just especially if we're sticking the hand on the wrist. It's just a very nice way to visualize those things in much better resolution. I would say that there's a bit of a learning curve to using the hockey stick, especially early on. If I recall, like in my, and personally, it's a little bit more difficult to navigate. But once you catch the hang of it, the structures in the hand of the wrist, the resolution is really nice with the hockey stick. But you should be able to get good enough to where it shouldn't matter what you're using. You should be able to get it both done with a hockey stick or a linear.
Sure. Next question. Do you have a certain scanning protocol when scanning the wrist?
Typically, yes. Typically, it's symptom driven. So I'm going to let my physical exam guide my protocol. If I'm suspecting ulnar nerve, if I'm suspecting median nerve or is a volar wrist, I'm going to stick with points 1, 2, and 3 on today's kind of the way I presented today. If I'm thinking dorsal wrist, like the scaphoulinae ligament that came in with a fall on an outstretched hand, or if it's somebody who comes in with a history of gout or inflammatory arthropathy, or dorsal located symptoms, you're gonna focus your exam on the dorsal aspect. So I'm going to go with points 4, 5, 6, and 7 on today's topic.
Great. Now, what you just said about pathology, how can you detect cysts and lipomas, and how can you tell what they are without getting pathology, a lab work done on it?
Well, I think you should be careful with how you if clinically, if you think that you need more work, if a more clinical workup needs to be done, then you should be very careful with your language and how you describe it. But you can always let your history and your anecdotal but clinical background so guide you there. So like, for instance, if you're seeing something that looks like a cyst, it's sitting in a place where you typically see cysts, such as the dorsal wrist, maybe or maybe not, it's getting tangled in the tendons. You're going to make a pretty clear insinuation that this is a cyst that is getting tangled in the extensor tendons, and go with that. But if it's like a lipoma or something that's a space occupying lesion, obviously, if it's a space occupying lesion that's not consistent with the cyst, or in an area where you're typically not you're not accustomed to seeing those things, you want to be more delicate with how you label it, and possibly have an additional read done by a radiologist or an additional imaging exam done.
Excellent. Last question for the evening. How is intersection syndrome diagnosed with ultrasound, and what do you look for? That's
a good question. So that's something I didn't describe today. Intersection syndrome is inflammation between the first and the second compartment, and is typically a little more proximal on the wrist. Right? So if your clinical exam is kind of leaning towards an intersection syndrome suspicion, a good way to use ultrasound to identify it is take that first point we talked about on the dorsal wrist. Okay, so on the radiostyloid, find that first dorsal compartment, move proximally, and as you move proximally, you're going to see that first compartment cross over the extensor carpi radialis brevis and longus, which is the intersection where the inflammation is going to generate. Okay, so I hope does that make sense in terms of description and maybe method of finding it? If not,
yes.
Then we'll have to maybe do another webinar on that.
Correct. Hey, Dr. Rigney, great presentation once again on the hand and wrist. Got a lot of great comments here. Appreciate your time this evening. And I'm going to turn it over to Frank.
Thanks, Mark.
You're welcome.
Thank you, Dr. Rigney. On behalf of Wisonic Medical, thanks for your excellent presentations. It is wonderful and enlightening. And we would like to cooperate with you for more webinars and other activities in the future.
Awesome. I would love to.
Okay, so Mark, thanks again for your efforts and your question. The questions you just asked helped us to know more valuable knowledges from Rigney, Dr. Rigney. Thank you again.
You're welcome.
And everyone in the broadcasting room, thanks for your watching today. I believe you must have got a lot of inspiration. And welcome to join our webinar on next Thursday again. Dr. Joe Sellers will present the 5th webinar with topic on ultrasound in MSK practice, HIP. So let's stay tuned. Thank you. So have a good evening, Colleen and Mark. So see you next time. Bye-bye.
Thank you, everyone. Appreciate it.
Everybody. Have a good night.